Wound care is something I've fallen in love with over the past year or so at work. I deal with a lot of wounds at work, or different types of wounds at work, but I've decided to really discuss specifically pressure ulcers today just because I've seen a lot of incorrect staging and mismanagement at work. Um, pressure ulcers are sores that develop over the bony prominences of the body, usually due to inactivity or an inability to change and move body positions. Prevention is the first step in the treatment of pressure ulcers. Pressure ulcers can occur in as little as 2 hours. So interventions such as turning and repositioning the patient every 2 hours while in bed is really important. And educating them and your staff on the importance of these interventions and devices. Um, Devices include things like air mattresses, wedge cushions, Roho cushions, and heel floaters. This is an example of a Roho cushion. These work by relieving the pressure to at-risk areas of the body. A stage one is a non-blanchable redness over the bony prominence of the body. Um, these are the easiest to heal since they're not opened. It's redness that's non-blanchable. These are the easiest to heal. I've healed out one of these in as little as 24 hours simply by putting the patient on a Roho cushion in his wheelchair and having him turned and repositioned every 2 hours, having him lay with a wedge cushion. A stage one is a partial thickness skin loss or loss of dermis. Excuse me. It presents as a shallow opened area with the absence of slough. These wounds, you're going to want to keep that healthy granulation tissue moist when you choose your dressings. So dressings like a leave-ins or a wet to dry can help depending on the size, location, and the condition of the skin. A stage 3 is a full thickness tissue loss. It can present with slough, and the subcutaneous tissue may be present. However, there is no bone, muscle, or tendon visible, and it may have slough, and there may be a degree of undermining and tunneling involved, and a lot of times there is. And then a stage 4 is a full thickness tissue loss, where muscle, bone, and tendon can be exposed. Most of the time, these two are going to require chemical debridement of some sort and eventually wound backing because they do get deep. So a stage 1 versus redness. Stage 1 pressure ulcer is not to be confused with redness. A stage 1 pressure ulcer is a non-blanchable. So if you touch it and it turns white, it is not a stage 1, it's just redness. However, redness is your warning sign that that patient is at risk for developing pressure ulcers. So certain interventions and devices need to be added to their care plan. And as well as education with the patient and the family and staff. Unstageable, this is where I see a lot of mistakes. An unstageable pressure ulcer is a full thickness dermis loss. However, the depth of the wound is obscured by slough or eschar. These cannot be staged until this is cleared out. Hence why it's called unstageable, because you can't physically see the depth of the wound. Another thing that I see a lot is wounds like this will be staged as a stage 3 or stage 4 because it's not black. The wound does not have to be covered in eschar to be unstageable. Like I said, if you can't physically see the depth of this wound, you have an unstageable pressure ulcer. This wound is gonna involve chemical debridement. This one's gonna need to be treated with surgical debridement and then probably chemical debridement after that. But like I said, the wound bed is not visible, so these are unstageable pressure ulcers. A deep tissue injury it can look like a bruise, however, it feels boggy or tender. It presents as a dark purple localized area, and the depth of these is also unknown. This is intact skin, and without proper management, it will open up. And usually what's under there isn't pretty. You're going to want to leave this open to air and have pressure relieving devices. So Santyl ointment works. Santyl ointment is an enzymatic therapy, and it works by eating away at the dead, nasty necrotic tissue, and it works over a 24-hour period. A nickel-sized thickness is recommended and needs to cover the entire wound bed. Do clean it and moisten it with normal saline or Dakin solution. Do not clean and moisten with dermal wound cleanser. Normal saline naturally activates the chemical and the ingredients in Santyl. And it's a really good thing to use with it. What I usually do is, depending on the wound, of course, using a wet to dry type dressing and cleaning it with normal saline and putting like a saline moistened gauze over and covering it with a dry dressing. Dermal wound cleanser deactivates the ingredients in Santyl, so if you use it with Santyl, you might as well not have even put it on at all because it renders it useless. And Santyl.com has a really good video on how to apply Santyl if you're interested.